Hello.
Yeah, Mr. Anand.
Can you send
this program, the first of the series in immunology and inflammation. I welcome Dr. Chandramani Pathak and Dr. Padumali Mahendran to take over from here on the sessions. Thank you, Chandramani and Padumali. Please carry forward.
Thank you, Dr. Sethu.
Thank you, sir. Very good morning to all of you. We welcome you all for the virtual bi-monthly lecture series on immunology and inflammation day 2 program. Yesterday, we had very nice talks, overview of immune system by Dr. Chandrasekhara, and cells of immune system and diseases related with immune cells by Dr. Dipankar Nandi, immunoglobulin functions and applications by Dr. Srinivas Kaveri, and complement system in physiology and pathology by Dr. Arvind Sahu. Today, we have eminent speakers. 5 speakers are there. And we will, can I have the introduction slide for the first speaker?
Yes, doctor.
Yes. I'm happy to introduce my colleague, Dr. Swaminathan Sethu.
Yes.
Dr. Swaminathan Sethu is a scientist, Grow Lab Research Laboratory from Narayan Nethralaya, Bangalore. He's a principal and co-investigator in basic and translational research interfacing ophthalmology and immunobiology. He graduated with bachelor's in dentistry, that is BDS from Tamil Nadu, Dr. MGR Medical University, Chennai, India. He then went on to do his graduate studies, MSc and PhD at University of Singapore in cellular and molecular immunology. He continued his career as a research fellow in NUS, University of Liverpool, UK, where he was working on tumor biology and immunological basis of adverse drugs. Currently, he is pursuing his academic and research career, primarily investigating immune-mediated pathologies of the eye and other organ systems, including COVID-19. He has authored and co-authored over 50 research articles in peer-reviewed international journals. He believes in evidence-based learning, translational, bedside to bedside, and preventive approaches in medical sciences. Over to Dr. Swami.
Thank you, ma'am. Good morning. That was very kind. So let me share my screen first so that it gets up. All right. So good morning, all. And thank you, Dr. Chandrasekhara and the SIR team. And it has been a wonderful evening yesterday. And I'm looking forward to the rest of the 4 speakers this morning as well. And I've heard all the 3 speakers, and I'm going to hear Professor Vani for the first time, so I'm looking forward to his talk as well. So I wanted to set the scene. Let me set my timer so that I don't go overboard. So the 4 talks which is going to come after this is going to be very contextual and going to be very informative. So I just wanted to set the scene with the basics. That's about it. It's a very simple task for me. And I just wanted to do it with a bit of a twist from the usual in terms of contextualizing clinically, because I was told that there were a lot of clinical colleagues as well who will be logged in this morning. So rather than just being very basic biology sense, I'm going to bring in a context to the clinics as well. And I'm going to attempt. I'm not sure whether it's going to come out well. So the outline is going to be, as I pointed out, a bit of clinical relevance and a bit on nomenclature. And how can we classify the various cytokines in general based on functions, and how can we measure and bring usefulness to the clinical relevance? Because often in many of the talks, they often say, yes, it is very good to know the role of these cytokines, but clinically I can't help my patient with it. So I wanted to touch upon that as well in the context of classification and function, not wandering away from that. So why do we need the knowledge of cytokines? Is that technically, you can use it for a variety of functions, including differential diagnosis, disease stratification, prognosis, and new target as well. In addition to your clinical data, imaging, or other clinical biochemical parameters. So cytokines can fit in and complement very well, provided we understand it in the context of its function with an organ system or with particularly to the disease. So that is the whole aim I wanted to do. And when it comes to the human body, it's an integrated network, and two common things which runs around connecting them, that is the neuroendocrine immune axis. The two common things are the endocrines and the cytokines. And they are important for the intercell communication, and Dr. Girtharlal and Dr. Amit and Dr. Balasubramanian will be talking about those communications particularly. And cytokines will talk to each other between the immune cells as well as the immune cells and the structural cells. So therefore, we do have to understand their role in the context of their communications between the different types of cells. And we do know, all of us do know and appreciate that the harmony or homeostasis in a tissue or an organ is a very continuous dynamic process. And it is very clearly evident from a whole lot of animal studies that there is an active interaction between the immune cells and the structural cells of the of any organ or tissue, and the cytokines, the secreted factors, are the most critical ones in maintaining this homeostasis. And often our clinical colleagues would say, oh, there's a whole lot of cytokines and everything looks similar, but it's very difficult to understand. As you see, this is a flight path of a time lapse taken from the Heathrow, but it all looks the same. But when you put in a grid, each one has a different altitude, different direction, different velocity and size and destination. So cytokines need not be an enigma because of these 5 characters. That is, it's pleiotropism. One cytokine does more than one job. It is synergic. It can join with other cytokines to do a particular job. It can be antagonistic. It can be redundant. But the more complexity comes because when there are multiple targets involved and multiple sources involved. But even this does not bog us down. But what bogs us really down is there are far too many of them and with many different names. So we can use all these 4 or 5 different aspects, that is the pleiotropism, synergy, redundancy, and antagonism, with reference to the tissue or target, we will be able to crack the code. Okay, that the code is to be clinically make it usable. And what are the different names? We call it monokines, lymphokines, cytokines, interleukins, chemokines. But if you look at the whole thing, the emphasis is primarily on the function, because you're going to harness it or target it based on its useful role or detrimental role. So we always have to remember cytokines in the context of its function and in the context of where it is. So what I've conveniently done is I've clubbed a few more of them into this cytokine world. It may or may not be right for the convenience of communication of secreted or soluble factors between different organ systems and different tissues. I've clubbed them together for communication. That is cytokines, you can call it chemokines, growth factors, and the 2 additional groups, soluble cell adhesion molecules, which can come off the cells, and soluble receptors, which also can come off the cells and float around. All of them are involved in intercellular communications. Okay, and how do we understand them better? That is, know their characteristic feature. They are usually, their secretions are stimulus oriented, brief, and cell limiting. Of course, we talked about the pleiotropism because I'm going to keep talking about it again and again. And they can target various cells in various organ systems based on their receptors, the cytokine receptors. But if you want to make a distinction between the cytokines or a growth factor or a hormone, pretty much you can see their solubility or receptor requirement is all more or less similar. So you can't make a clear distinction based on the certain properties, but yet there are some differences. So, and that differences will come in the contextualization with reference to a disease or an organ system. Okay, and we are aware, we talk about cytokines, they do not magically appear. They are always in response to a stress or a stimuli, or whether it's a favorable stimuli or a noxious stimuli, or numerous genetic factors. Okay. So this is the one which one of our clinical colleagues said, there are so many of them. Where do we go and have a consolidated look? So there is a place which you can go, that is the COPE. It's called Cytokines Online Pathfinder Encyclopedia by Hof Engelbost. For many years, it was free, but now you have to have a very minimal subscription, or you can donate. It has more than 50,000 entries, which in different combinations of cytokines available for us to use its information clinically or even in our biomedical research. This is a good site for us to go to. And how do they communicate these cytokines? There are three ways again. If they can bind to its own cell when after it gets produced, it's autocrine. And of course, if it goes to the adjacent, which is another cell, it's paracrine. And if it takes a longer route, it's called endocrine signaling, but it's not hormone per se, but if it travels. But once again, we have to understand this entire signaling process or communication in the context of the tissue, in the context of which cells they are going to go bind to, and whether the pleiotropy or redundancy which we talk about is actually redundant, or is it lack of information. Okay, so we can take an organ tissue, or we can take a disease in particular, and then bring about these various classes of cytokines into the picture. But these are the traditional forms. I've put the yes, alphabet S in yellow, because there are multiple classifications based on multiple functions. And two common things is based on the structure or the family of the protein, that is the cytokine themselves or the receptors, or is based on the function. So it's basically two types always, either based on structure or based on function. But it's always easy for us to remember function, because you can always relate it to an organ system or a disease. But if you look at it, I just put the bottom right is just for visual appeal. It's like, looks like a periodic table, isn't it? But this is based on structure. All the different cytokines based on their families, based on their molecular and structural similarities, it has been grouped. Okay, but this is going to be very difficult to remember. But if we do find it easy to remember if it is based on function, whether it's pro-inflammatory or whether it's anti-inflammatory, whether it's innate or adaptive, whether it helps in T-cell differentiation, whether it's pro-angiogenic or anti-angiogenic, pro-nociceptive or anti-nociceptive, pro-neurotoxic or pro-neuroprotective, neurodegenerative or regenerative, fibrotic, tumor immunity, in osseointegration, metabolism, hematopoiesis. If each one of you have different interests, you can take these cytokines and classify them based on the context of the function or the area of your research or your clinical expertise, and have your own classification which is usable. And how about these functions are brought about is binding to their respective receptors on the cell surface. And this will be covered by the subsequent speakers. I'm not going to elaborate and make that redundant right now. But the type of receptors and the family are very crucial for mediating their function. So it is not just one cell they are going to bind, and it is not going to have one direct effect. A stimuli can create a cascade. Okay, so one set of cells will produce them, another cell will receive those cytokines and further respond and secrete even for additional milieu or a distinct milieu, which will determine the fate of the target tissue or an organ. So it's a cascade effect, one we have to remember. The yellow might be of a different classification functionally, and the red ones, the red dots which you're seeing, could be of a different function if you wanted to classify. So I just wanted to drive that point. Every time we can contextually classify these cytokines rather than sticking to the well-known one. Of course, we do need to appreciate the well-known ones. And here, these are the cytokines with hematopoiesis. I'm just checking the time. Just give me a second. I have 10 more minutes. With the reference to hematopoiesis, you can once again broadly classify into how they're going to drive the myeloid cells and the lymphoid cells. And once again, you can take these cytokines and say they are going to drive these subset of myeloid cells and lymphoid cells. You can classify it based on them. You can, based on the immune arm or the associated cells, you have a whole host of them, which is going to interact. But it just gets murky because there is absolute no clear-cut division. A certain type of cell will only produce certain set of cytokines. But however, you can contextualize it based on the kinetics, whether these cytokines are coming from the innate cells or the adaptive cells, based on the kinetics post-stimuli or infection or injury. So based on that, you can do these kind of simple groupings based on hematopoiesis, innate, inflammation, chemokine, or specific immune response, whether it's a T cell or a B cell or class switching, which we all were aware after attending yesterday's class. So you can take a group of cytokines and classify them again. The reason why I keep repeatedly saying that is classification is something which we have to continuously do in a particular context. And this is a functional categorization of cytokines based on the T cell subsets. And you can use these cytokines based on signature cytokines or the cytokines which actually drives these subsets. The ones, cytokines which is boxed in blue are the ones which drives these subsets. The ones which are boxed in red are the ones which are produced by them. Once again, the context, when you're calling Th1 cytokine, you can call them the ones which are producing them or the one which is inducing the particular subtype. So the words are important so that the clarity gets communicated very easily. And based on these, you can call it Th1 or Th2 cytokines based on what they produce, pro-inflammatory or anti-inflammatory. These are very simple listings, but the listings actually changes with reference to the type of stimuli, the type of disease, and the type of organs, okay? So that's why I've kept it simple in terms of classes, and the classes can always be dynamic in terms of who is going to populate each of these classes. And this is one of my attempts to put all of them in one table, but it looks simple, but yet it is not all inclusive. So therefore, we need to contextualize it individually. Say, for example, if you take pro-angiogenic versus anti-angiogenic cytokines, we need to know the exact roles of these stimulators and inhibitors, and which aspect of angiogenesis do they actually play, whether they are involved in activation of endothelial cells or degradation of the basement membrane for the vessels to grow or vessel stabilization, or more particularly, which stage of these angiogenic processes, like sprouting or stabilization of actin changes in the leading edge. So each one of these can be classified and subclassified on the context. So therefore, we can harness its role or target its role effectively. The next group, you can classify it based on pro-nociceptive and anti-nociceptive cytokines. And these can increase or decrease the threshold of nociception, thereby enabling one to have hyperalgesia or allodynia or analgesia. Okay, so these are just not cytokines, these are just not inflammation, these are pleiotropic, one guy doing multiple functions and different functions in different organ systems and different sensory perceptions. Okay, so it is important for us to understand, to know how the interplay between these cytokines and classic pain mediators like substance P or CGRP, because these are actual nociceptive agents or which drives the pain sensation, but cytokines do play a role in facilitating or the potency of these well-known nociceptive drivers. Therefore, they can be classified under pro and anti-nociceptive cytokines. And the psychology community has also started classifying based on their association with the positive moods, negative emotions, depression, and so on. Once again, if you are a clinical psychologist, you can once again classify them based on the condition which you're treating. And if you're into neuropathies, if you're a neurologist managing, or even an ophthalmologist managing optic neuropathies, you can take these cytokines, not just call them pro-inflammatory and anti-inflammatory, but put them in this context of neuroprotective or neurotoxic, okay? And in that patient, what is the dominant one, which is probably driving the neurodegeneration? Or say, for example, IL-6 is pro-inflammatory, often gets a bad guy's name all the time, but it is necessary for axonal regeneration, okay? So we always have to bring the classification in the context of what we are looking at. Fibrosis, again, you have a whole bunch of pro-fibrotic and anti-fibrotic cytokines. Don't just call them Th1, Th2, or anti-inflammatory or pro-inflammatory if you're looking at ECM remodeling, extracellular matrix remodeling scenarios. And osteogenic, I think Dr. Vani is going to talk about it. You have a whole lot of cytokines which facilitate osseointegration or modulate osteogenesis and osteoclastic function. Once again, if you're having a bone-related pathology or an implant failure or implant integration, we have to talk about these key factors, cytokines, in the mix, and we have to group them as to whether you have a favorable balance towards each other. And everybody knows about tumor immunology now. So once again, you can classify them based on tumor supporting or tumor opposing group of cytokines, which will enable you to facilitate anti-tumor immunity and or even improve response to therapies now. I'm not getting into the various immunotherapeutic modulation, but my context here is if you're dealing with cancers and if you're looking at remission or relapse or regression, you can have these factors, group them for profiling. Why I keep talking about these classification is for a clinical context, which I'm going to end in the last couple of slides. And more recently, cytokines are known to change metabolic pathways. And I think Dr. Balasubramanian is going to be talking about the metabolism part. So once again, you can classify the cytokines as those which drives glycolysis or lipogenesis in the context if you're looking at a metabolic disorder. So this is what I started with. I'm coming back to this. The knowledge of cytokines, the classification, the context of the disease is going to be absolutely important, but it'll only be useful if it is going to be measured accurately, like so that you can use it in a very disease-specific management strategies. Okay, for that we need to measure. How do we need to measure? Is we know that we can measure by ELISA. But there are other ways you can measure as well as like multiplex ELISAs as well. I have a minute and I'll be ending soon. So now I want to drive the clinical usefulness, single cytokine versus cytokine signature approach, because we need to know that one, we have to move from single marker or a single cytokine to a signature approach, because we, being in a clinical setup, we are realizing that the same disease phenotype with the same group of cytokines, but the key drivers within the group are different among the different patients with the same disease. So if you're looking at just one cytokine, you can actually miss that particular disease and classify, okay, this is not going to fare well or not. Okay, so it is important for us to get a signature to classify rather than taking just one cytokine. I have one more minute. I'm sorry? Okay, somebody else is talking. Okay, so the level of cytokines always have, the level of cytokines has to be always correlated with clinical features for usefulness in an objective manner. If you have an imaging system or any kind of quantification so that it is useful, clinically. Okay, and also you have to use some. Every clinician and even biomedical researchers are very concerned that we don't have normative data. Yes, we do not have normative data because multiple platforms of huge population. But we have to find the balance by normalizing between two cytokines. Okay, so with that with that addressed, we also have to know whether we have to measure locally or systemic, or we have to find out what sample you can actually use to classify them. Is just if you're looking at, say, a neurological condition, if your ideal situation is going to be a CSF, you can't get CSF because it's a very invasive procedure. So studies have to be conducted to use a non-invasive or minimally invasive sampling method to get the correlation and use that as your surrogate system. Okay, so that using that, you can classify the cytokines in that particular condition, whether it's going to be useful or not. And the second important part of knowing the classification and measuring them is titrating if you're going to block them. You do not want to bring subnormal state or levels of critical cytokines. Okay, if you're going to assume that this is an angiogenic condition and you're going to give an anti-VEGF, and if the VEGF is in that particular individual is not the driver, but it's probably angiopoietin, you're going to go in heavy with your anti-VEGF, and you're going to bring down to subnormal levels, and you're going to trigger an alternate response, which you're probably not going to comprehend. Okay, so that was quite true with cytokine storms. We know about cytokine storms because of COVID. I'm so sorry to say that, but yet we got to know more about cytokine storm because of COVID. But adverse drug reactions and other conditions have caused this. But the reason I wanted to point here it out is some of my clinical colleagues have said, who are managing the severe sequelae, said not all patients are responding to tocilizumab. Okay, so IL-6 is not doing magic in all of them, but it is doing wonderful response in a subset of them. Okay, so therefore we need to know which group is producing. That's why the importance of signature, the importance of classification comes in with reference to these kind of scenarios. And therefore we need to bag the right guys and not bag all of them and deprive its homeostatic role. Okay, in order for us to get recovery versus immune paralysis or shock, there is always a balance. And if you know that if you classify if there are 3 cytokines which are doing its redundant job, the otherwise redundant job, you can know that you can actually pick one of them to dampen the disease rather than just mop the whole thing up. Therefore, contextual classification of cytokines would be extremely useful. So all this knowledge is coming purely because of my interaction with the clinical team, because or else I would have just been classifying it in a textbook manner, but not in a clinically useful manner. So I am extremely grateful for all the clinical inputs coming from our clinical colleagues. And of course, our lab team has been phenomenal in setting up this entire cytokine profiling platform here in Narayana for us to understand cytokines in much better detail. Thank you. I'll be happy to take questions.
Thank you, Dr. Swami, for excellent presentation, especially covering up the clinical view. And now the talk is open for the discussion. Any questions for Dr. Swami?
I'm sure it's basic. So
yeah.
So, Dr. Swami, I would like actually just curious to know about how IL-6 actually balance the metabolism.
Ah, right. Perfect. Give me a minute. So a simpler starting point is because of it binding to its receptor on multiple tissues, depending, let me go to that slide so it's easier, including adipose tissues. Okay. Give me a second. I used IL-6 as an example. There are a lot more cytokines which are there, which is doing the same thing, or not different things. So you could see that in white adipose tissue and brown adipose tissue, it is going to alter the adipokines, and the adipokines are going to influence your skeletal muscle or your other cells, glycolysis, lipolysis, or even oxygen consumption rate, all of them. It depends on the balance. If you're going to ask me a particular pathway, it is going to be dependent on the cell. That is why I talk about the signature. If you're going to have an hypoxic environment or a nutrient-rich environment versus a nutrient-deprived environment versus a high fatty acid environment, the IL-6 or any cytokine for that matter could have differing effects based on its signaling cascade. If my answer is a bit vague, I'm sorry about that, but that is actually the case.
So
It is context dependent.
IL-6 is specific or other inflammatory cytokines like IL-beta, IL-18?
They do.
So
All of them do.
they have to influence the metabolism?
It does. It does. Yes, it does. I just put this as an example. It does.
So I don't think is still any molecular mechanism is known about how is actually influencing the metabolism, because I'm just I'm curious to talk about especially the mitochondria and energy metabolism.
Right. So I've heard Dr. Balasubramanian speak about it. So he's an authority in that. If he's still there, I would request him to suggest, because he's the expert. I'm not into metabolism yet.
Yeah. Okay. Thank you.
But I'm a follower of metabolism. But if Dr. Balasubramanian is there, I think he can help. I think he's going to speak about it as well. But it's a signaling cascade. For example, we have used IL-17 in a T cell, okay? And when we blocked it with different inhibitors, we had a different metabolic pathway, okay, activated. The second one is we have recently published the PD-1. Everybody would know about the immune checkpoint inhibitors. The PD-1, the use of PD-1, it helps metabolic reprogramming in T cells. Okay, so each of these stimulus versus receptor-mediated signaling rewires how the cell uses energy and how it looks for different types of energy sources.
I just like to know IL-10 IL-6 ratio is elevated in case of intraocular lymphoma. How it works?
Absolutely, sir. Absolutely. In fact, thank you for pointing that out. That is the example I wanted to give in one of the things I said. When the absence of normative data, we have to use ratios, right? So IL-6 IL-10 ratio is very useful, and Dr. Padma Malini is there. She has tried to diagnose intraocular lymphoma with IL-6 and IL-10, and she gone one step further to see whether that kind of diagnosis can be made using non-invasive methods as well. So our attempts are there. You're absolutely right. So thank you for pointing that out. Yeah.
You're working on various ocular specimens and evaluation of cytokines. The tears is the simplest and the non-invasive way. So how sensitive are the tears in estimating the ocular autoimmune diseases? Can you share your experience on that?
Absolutely. Our intention is to go towards perfection, okay? So we have found out that different platforms will give different levels in terms of picogram per mil based on the individual assay's sensitivity, okay? Based on that, we should not think if this is high or low or subnormal or abnormal. So while we were doing that, we realized it is important for us to look at signatures, okay? And also there is a computational method which is being published not by us, but from a group in America, where they're using mathematical modeling to use cytokine information to arrive at a useful information in diagnosing not only autoimmune disease for any diseases that matters. But in simple term, our experience is not just one cytokine. We have to look at signatures. The second thing is we are computing ratios within the cytokines. Say, for example, like Sir said, IL-6, IL-10 ratio is very important for us. Likewise, we are trying to do VEGF and PEDF for angiogenic factors. For nociceptive factors, we are trying to do VEGF-A and VEGF-B. So likewise, these tier inflammatory factors in disease context, we are bringing the function and then get the ratio between the two cytokines to arrive at a meaningful readout rather than just a number.
Sir, we also done it on a couple of patients, IL-10 by IL-6, not only for the diagnosis and also to study the disease course. in addition to the tears,
Yes.
ocular fluids, the aqueous, the vitreous tumor, and also the CSF also is used to evaluate monitor the course of the lymphoma in estimating the IL-10 by IL-6. It is really a useful one indirectly
Absolutely.
to assess the disease course as well. Thank you.
Yeah.
So